Hello, everyone, and good afternoon, and thank you for joining this session at the 30th Alzheimer Europe conference. This session is on the presentation of a new European Academy of Neurology guideline in medical management issues in dementia. And my name is Kristian Steen Frederiksen, and I'm a consultant neurologist at the Danish Dementia Research Center in Copenhagen, Denmark. I will be giving a brief presentation of the guideline, and then we'll move on to a Q&A session. And joining me for the Q&A session, I have three of my co-authors on the guideline, Professor Anna Verdelho from the Department of Neuroscience and Mental Health in Lisbon, Portugal, and Professor Milica Kramberger from Center for Cognitive Impairments at Ljubljana in Slovenia, and Dr. Kristian Nilsson, who's head of the department at Department of Neurology and Rehabilitation Medicine in Lund in Sweden. And I urge you very much to fire away with questions in the chat function in Zoom, and then we will have those questions answered in the Q&A session by our panel. So with no further ado, I will move on. So this guideline has been published in the European Journal of Neurology and is available. And this is really a concerted effort with participants from across Europe. Apart from representatives of the European Academy, we also have representatives from the European Association of Geriatric Psychiatry, the European Geriatric Medicine Society, the European Alzheimer's Disease Consortium, and a patient representative embodied by Jean-Georges from Alzheimer Europe, which we are very pleased to have on board. So why is it important to develop a guideline on medical management issues? Well, there are several reasons for that. We know that many patients with dementia have a neurodegenerative disorder, and we can unfortunately not at present cure any of these, but the diseases are to some degree manageable in the sense that we can treat certain symptoms as well as comorbidities, and that this leads to a higher functional level and improved quality of life. We have focused on dementia as a syndrome in this guideline because many of these management issues are shared across dementia diseases. And we know that there are unmet needs and also significant variation related to these management issues across centers, regions, and countries in Europe. And we also know that mismanagement of these medical issues can be associated with negative health consequences and additional costs. So based on these issues, we selected a number of medical management issues that we wanted to address in the guideline. And obviously there are a lot of issues that we could have chosen, but we decided on these 5 because we thought that these were the most pressing. And these were systematic medical follow-up in patients with dementia, management of vascular risk factors in dementia, treatment of pain in dementia, treatment of agitation and aggressive behavior with antipsychotics in dementia, and management of epilepsy in dementia. And I just very briefly want to lay out the methodology that we used for developing this guideline, which was the standard operating procedure for all EAN guidelines, and is based on the grade system. And basically, if we start from the left of the slide, anyone developing a guideline, for example, starts with a research question, and this is changed into what is called a PICO question. PICO stands for population, intervention, comparator, and outcome. And then evidence from the literature is gathered and rated according to how much one trusts the evidence, and then presented to a panel that comes up with some recommendations. And these recommendations can either be for or against the treatment. They can be weak or strong. And finally, the panel can also come up with what is called a good practice statement, meaning that if there's no evidence, the panel might still believe that there's a reason to give some guidance on the area. So a strong recommendation means that the benefits outweighs the harm for almost everyone. So all or nearly all informed patients would likely want or not want the treatment option, depending on if it was a recommendation for or against, whereas a weak recommendation Here the benefits outweigh the harm, or vice versa, for the majority, but not for everyone, and a substantial number of patients would likely have or not have the treatment. I just want to go in a bit more detail with a weak recommendation, because this can be a bit misleading. So a weak recommendation might stem from a lot of some evidence suggesting a large effect, but low quality evidence, or evidence of a small effect from high quality evidence. And these are, of course, two different situations. So that was a bit about the background and methodology. Now I'll move on to the recommendations. So for the first one, systematic medical follow-up in patients with dementia, we came up with a good practice statement, meaning that there was no evidence to guide our decision or recommendation, and we came up with the advice that patients with dementia should be offered regular pre-planned medical follow-up, and the setting will depend on local organization. Then for management of vascular risk factors in dementia, we formulated two research questions. The first was, should patients with atrial fibrillation without previous stroke, but where there's indication for anticoagulants and dementia, be treated with anticoagulants? And we came up with a weak recommendation for treatment with anticoagulants in patients with dementia. The second research question was, does systematic management of vascular risk factors in patients with dementia slow the progression of dementia? And here we did not find any evidence and came up with a good practice statement saying that systematic management of vascular risk factors should be performed in patients with mild to moderate dementia, since prevention of cerebrovascular pathology may impact on the progression of dementia. Moving on to treatment of pain in dementia, we formulated two research questions. The first one was, in patients with dementia, should opioids be discontinued? And here we did not find any evidence again, so we came up with a good practice statement saying that discontinuation of opioids should be considered in patients for whom there's no complaint of pain and no clear indication, where mild analgesics have not been tried, and in patients in whom there's suspicion of side effects. The second research question was, should behavioral symptoms in patients with dementia be treated with mild analgesics? And here we came up with a weak recommendation against treatment of behavioral symptoms in persons with dementia with mild analgesics. Moving on to treatment of agitation and aggressive behavior with antipsychotics in dementia, we formulated three research questions. The first one, should patients with dementia and aggressive behavior agitation be treated with modern or atypical antipsychotics compared to no pharmacological treatment? And here we came up with a weak recommendation against treatment of patients with antipsychotics, with dementia and agitation, aggressive behavior with modern atypical antipsychotics compared to no pharmacological treatment. And the second research question was to compare modern or atypical antipsychotics with haloperidol, and here we came up against with a weak recommendation for treatment of patients with modern atypical antipsychotics when compared to haloperidol. And the second research question was, the third research question was, should treatment with antipsychotics routinely be discontinued? And here we came up with a weak recommendation for discontinuation in patients currently treated with antipsychotics. Then for management of epilepsy in dementia, we formulated a single research question. Should patients with dementia and one or more seizures after diagnosis be treated with either levetiracetam, lamotrigine, or carbamazepine, phenytoin, valproate? And here we again, unfortunately, did not find any evidence to guide our decision. So we came up with a good practice statement saying that newer anticonvulsants, including levetiracetam and lamotrigine, should be considered as first-line treatment of epilepsy in patients with dementia due to their low potential for drug interactions, lower incidence of adverse effects, and linear pharmacokinetics. So that concludes my slideshow, and we can now move on to the Q&A session. I will just see if I can see the chat. And please, to all the audience, please let us have any of your questions in the chat, so I can pose the questions to our panel members. But while the audience thinks a bit and comes up with some questions, I can maybe start with you, Professor Verdelho, a question about the vascular part of the guideline. So in your opinion, as a clinician dealing with both vascular neurology and dementia, how important a role should management of vascular risk factors play in the practice of a clinician who is in charge of managing patients with dementia?
Thank you, Kristian, for your nice introduction and for this explanation. And I thank you also the EAN and this organization of the Congress for launching this initiative in these strange times. And taking your question, vascular risk factors are recognized as one of the important determinants of cognitive impairment associated with aging. And this is true not only for vascular dementia, but also for Alzheimer's disease. And this is so important that 3 years ago, the publication of the Lancet Commission on Dementia suggested that around 35% of dementia was attributable to a combination of modifiable risk factors, which included vascular risk factors. And being potentially modifiable, and really they are potentially modifiable from early ages as midlife hypertension or obesity, vascular risk factors management can potentially consist in one of the best ways of preventing dementia in next decades. So I think that vascular risk factors management can somehow be neglected in patients with dementia. And I think this was our concern because of several reasons, including patients may not complain, or relatives are too overwhelmed by other issues, or even clinicians from memory clinics may have less experience in managing vascular disease. And we know that there is an uncertainty about the management in vascular risk factors among patients with dementia. So this might lead to heterogeneity in the treatment of those patients. So it is my opinion that once a patient is seen in a memory clinic and diagnosis of a cognitive problem or a dementia has been confirmed, the presence of a vascular component should always be considered and explored in that specific patient. I hope I have answered your question.
Yes, I think very much so. So I think your take-home message would be that it is quite important, and actually this is something that in some on some level can be considered a disease-modifying therapy. That by treating these vascular risk factors, we can actually, in some patients, modify their disease trajectory.
Yeah, because they do not, vascular risk factors, they do not only increase the risk of dementia, they modulate, they even can aggravate the expression of the clinical picture. And on that sense, to acknowledge the vascular risk factor in a specific patient can change the clinical manifestation. Yeah. And I think this is really relevant, so it should be part.
Yeah. I think you also touched on a very important issue, and why we wish to address vascular risk factors, because we had a feeling, and I think there's evidence also to corroborate this in the literature, that there is a risk or a danger that some patients with dementia will not get the treatment for vascular risk factors that other patients without cognitive impairment receives. Can you suggest any of the barriers on the physician side to ensure proper vascular care? What are they worried? What are they concerned about? What are the issues? What are the prejudices, so to speak?
I think there are several reasons. In fact, in some way, sometimes the patient and the relatives are too concerned with other things like behavior or loss of cognition. And in the other way, sometimes we have the doctors that we don't have too much evidence from studies published to support clear recommendations concerning specific treatments like antithrombotic use or like anticoagulation, like we approached. And so the clinicians may be afraid because they may be afraid due to concerns of side effects or the uncertainty of some patient adherence of the treatment. So, and we have some evidence from some publications that the level of care received by people with dementia is lower than the level of care received by people without this diagnosis. And there is no way we can think that persons with dementia will not benefit as the others from the good approach of vascular risk factors. So this is really something we need to overcome is some less of care in one side and some less of evidence to not preclude the best vascular care of the patient, in fact.
Excellent, thank you. So we hope that this guideline, we can be a stepping stone towards better vascular care for patients with dementia. Thank you for that, Professor Verdelho. I want to move on to another issue addressed in the guideline, and I'd like to move to you, Dr. Nilsson, on epilepsy. So for the research question on treatment of epilepsy, there was no evidence available, and we came up with a good practice statement, the guideline. Could you go through the recommendation again and maybe elaborate a bit about the motives and the reasons for coming up with this good practice statement?
Right. So the background is that there is quite some evidence, at least in comparable patient groups like elderly people without dementia, that the older traditional anticonvulsants like carbamazepine, valproate, and phenytoin, and also phenobarbital has quite a number of adverse effects, especially cognitive and sedative side effects. Also, there are much more interactions and difficult pharmacokinetics compared to some of the newer anticonvulsants, including the levetiracetam and lamotrigine that we chose here for comparators in our research question. So as this as a background, we wanted to address this question. And even though there is only one study comparing levetiracetam and lamotrigine with phenobarbital, which was not a research question, which did show that the side effects and those stopping treatment because of side effects are much more pronounced for phenobarbital and the others than compared to the newer anticonvulsants, and also that the efficacy is the same. So there are the same amount of seizure freedom is attained irrespective of which treatment you choose. And this is corroborated in at least 4 randomized controlled trials for older people without dementia. And therefore we feel comfortable with our good practice statement. And then there are a number of other sort of supplemental considerations that we should address, but maybe you want to come back to that.
We can. I think one thing that I often hear is that at least in Denmark, a lot of physicians are concerned about the psychiatric and the cognitive side effects of levetiracetam, I think it varies very much from physician to physician. Some seem to be very concerned about it. Some seem to be less concerned about it. I was wondering if you could give your personal view on this, and also if you have a sort of a go-to drug that you choose for those patients with dementia that also have epilepsy.
Yes. So first of all, there is actually some evidence that levetiracetam, even in one study, improved cognition slightly during a 12-month follow-up, while lamotrigine and carbamazepine, in those groups, the patients deteriorated, which is also, of course, expected in dementia. But there's no real evidence that levetiracetam does decrease cognition. However, there is in a certain proportion of patients, far from the majority, a risk for enhancing or depression, or maybe giving some degree of irritability. And of course, in those patients with dementia that have these psychiatric complications of the dementia disease, levetiracetam might be less favorable, and that would mean that we would try lamotrigine. Lamotrigine, on the other hand, takes longer to uptitrate. So one of the factors that for me decides which one I would choose would be how urgent is it to reach a sort of a reasonable concentration. So if it's a bit urgent, I would choose levetiracetam. In the low doses that you use, usually like 500 or 1,000 milligrams a day of levetiracetam, I seldom see any sort of prominent side effects. Lamotrigine, you might need to go higher up in dose, and that could take some time then. And also there is actually a certain risk for osteoporosis with lamotrigine long-term treatment, which as far as I know, does not apply to levetiracetam. So as usual, as in normal, all other epilepsy patients, you have to individualize your treatment.
Yeah, I think that's an important message, the individualization of therapy, no less so than in patients with dementia. Now, as you also stated, we recommend the newer AEDs, so to speak. Are there any patients with dementia where you would nevertheless go for the older drugs, or is it, in your opinion, a definite no-go in patients with dementia? I know that you have we have talked about the valproic acid as one of the maybe drugs that you have to be very careful with. But I don't know if you could elaborate a bit on.
So, I mean, there will be a certain proportion of patients that would tolerate moderate doses of carbamazepine, for example, or phenytoin. And I suppose that if all other newer anticonvulsants are not tolerated for some other reason, sort of, or less suitable, it's of course not forbidden to use these. I very, very, very seldom would initiate valproate more than as an urgent intravenous treatment in the status epilepticus situation. There are so many known side effects of this nowadays. So I would be very careful with that. But I think also if you add a few other of the newer anticonvulsants, there are a number of alternatives, and I would come very far down on my list to use the older ones nowadays. But sometimes it could be a question of efficacy in the individual patient, where you actually attain something with the older ones, which you would not attain with the new ones.
Yeah. So again, back to the individualization of therapy. Thank you very much, Dr. Nilsson. Then I would like to move on, and I still see that there are no questions from the audience, but please feel free yes, actually I see that there's a question from Joey now on epilepsy, so maybe we can return to you, Dr. Nilsson. Joey asked, does epilepsy increase risk of dementia in later life? I don't know. That's a bit beyond the scope of the guideline. I don't know if you can answer that question, Dr. Nilsson.
I'm not aware of any evidence supporting that, although I would say that if you have a very an unregulated epilepsy, for example, a temporal lobe epilepsy, that you have not been able to control with very frequent epileptic attacks through a number of years, you would probably increase the risk of dementia, at least if you get some other comorbid condition as well. And then one could also turn it and say there are examples then, not least, especially with the valproic acid, where a dementia-like condition has been not attained, but I missed the word now, but induced by chronic treatment with valproic acid, what one calls valproate encephalopathy, which one has to be aware of exists. And there is a study in Neurology from 9 years ago where one tried valproic acid as a treatment in Alzheimer dementia with the thought that subclinical epileptiform activity could worsen the cognition. And they actually had an increased rate of atrophy in the treatment group compared to those with placebo. So one should be very aware of that. And I think it goes both ways. But normally it would not, I would not say that epilepsy increases the risk of dementia, no.
Okay. Thank you very much for that question. I will move on now to Professor Kramberger. And could you talk us a bit through the part on management and start by giving us a bit about the motivation for including management of pain in dementia in the guideline?
Yes, thank you very much. We all know that pain is actually a very common condition in all lifespan, but of course in the time of the person when it's more likely that one will get dementia, there are certain other concomitant diseases which are more often present. Of course, we talk about the degenerative diseases of joints and bones, and we are very well aware that people who are older would more often have that kind of pain present also, and also of course other diseases besides dementia. And when we are dealing with a person who has dementia, we of course are always aware that the pain as it is has many characters, has many aspects. It can happen, or it can come on in certain situations. So, for example, after a long walking, or it can come on after being bedridden for a longer time. Or so, in patient who has dementia, we are aware that many of them have problems in interpreting or verbal reporting of a problem. It can be a pain, or it can be any other problem. So here we are facing the big issue of a possibility of not knowing that the person really has a pain. So the pain, therefore, is an important symptom and important thing that we should be aware. But in the same sense, we also have to be aware that by treating the pain, we know that we have different types of analgesics with several possible side effects and interactions with other treatments that a person can have. So we really should be very careful. And as I said, as dementia is worsening, the information from the patient can be missing, or can be misinterpreted, the level of pain, or can also be maybe interpreted as some other problem. Here we come to another point where actually the carers are those who are maybe the one who are reporting about the pain, and we have to take this into account also, that maybe this interpretation, of course, can be relevant and valid, but also can be wrong. This is also, we have support in that also from studies where they were actually using the information from the carers and from, for example, from the staff. And it hasn't been shown that it's always the assessment really relevant or the one which could be relied on. So it's a difficult issue, and as it comes on more oftenly when the disease is more advanced, where the dementia is more advanced, that's why it's really important that we think about this problem and try to decide really on again, as we have said today, on an individual situation each time.
Thank you for that. I see that that we have maybe a question or perhaps more a comment on this pain issue from Gail Henry, and I just want to read it out, and then we can maybe discuss it. Gail writes, "This is a really important point. Often in practice, pain meds are prescribed as required, and staff often report they are not administering it as they are not being asked for it. Distressed behavior often is a communication of pain which gets missed at times by staff and referred to mental health services. They forget about other comorbidities which may also cause pain." So I don't know if the I guess that it is sort of a problem to have this as required medication, because it can lead to both over and under treatment. In my experience, not only with pain medication but also with antipsychotics or benzodiazepines. But on the other hand, we actually address the issue of treating behavioral symptoms with analgesics in the guideline, and come up with a weak recommendation against treating behavioral symptoms with mild analgesics. And I'm not sure that this point is really in opposition to what Gail is saying. I don't know if you want to elaborate a bit about our statement with regards to this issue of treating behavioral symptoms with mild analgesics.
Yeah, as you said, we have found that there is no, I mean, we found only one study which we could include it, but otherwise from the practice, we know that this is quite a common, it seems that it's a common situation that people are trying to use the analgesics for somebody who is maybe agitated, or somebody who is seems to be somehow different in performance, and this is especially common in the nursing homes. And of course, by doing that, of course, you can cover maybe the pain which could be present, but there is, of course, a problem that other causes of agitation or some sort of behavioral problem can be missed, which are very important too. And we are all aware that when we have a person with dementia, with the onset of a different behavior or performance, we should always think about the possible causes of so-called delirium, like infection, dehydration, and things like that. So I think it would be probably, or not probably, for sure wrong to just to decide and use the analytics and say, okay, this is it.
Yeah, I think that really, apart from the fact that, of course, we looked at the evidence to come up with this recommendation, but also what we are elaborating a bit about in the guideline is this exactly as you put it, that it's important that we do go through a diagnostic process in order to identify underlying causes of the behavioral symptoms. And of course, we acknowledge that this may be pain, but it may also be a lot of other things, those that you mentioned. Yes, thank you very much. I also just, Dr. Kramberger, just want to go to the issue of opioids, which we also address in the guideline, where we give a good practice statement for stopping opioids in patients with dementia. Why is it a good idea, or why, in other words, is there a concern regarding opioids in patients with dementia? What are the issues here?
Yeah, we know that opioids, of course, should be used for a severe pain. And of course, patients with dementia can have severe pain accompanied by a malignancy, which they have also, or they have been, I don't know, in a palliative phase, end of life phase of the disease. Of course, there we can imagine and expect that this person can be in a severe pain. But of course, we also have to know or be aware that opioids are very strong drugs, which have several possible side effects. Among them, one which is very, very important is the cognitive worsening. And with a patient who has already declined, of course, we would not want to have this additional worsening due to opioids. And we know that patient can be, I don't know, dizzy, can be more prone to falls. They can feel nausea, they can be obstipated, and in addition, we also can see from the practice that they can be more in a bigger risk for getting the respiratory infection and be again at bigger risk for maybe death. It is actually known from the studies that as the antipsychotics, also the opioids can be or are very frequently used in the dementia patients, and this is the situation which is actually putting the patient into a worser condition. Of course, it can be more calm, the person, but all these side effects that I have mentioned, of course, are causing additional problems, and of course are probably also leading to a earlier death of a person.
Yeah, I think that put it very nicely, and I guess that one of the concerns, and a bit the same concerns as with antipsychotics, that the use of antipsychotics is often based on trying to induce a sedating effect, and one could be concerned that with the focus on antipsychotics and mortality, then opioids might substitute antipsychotics as a sort of a way of calming or sedating patients with dementia who have behavioral and psychological symptoms. And as you put it, there's reason to believe that these patients will be more prone to side effects of opioids. Okay, I have a further comment from Gail, also on the analgesics, and she writes, I think the lack of research is perhaps indicative of the difficulty to test the hypothesis due to the client group, especially with advanced dementia. Analgesic use is a decent first-line treatment, especially with potential underlying conditions such as arthritis and other common age-related conditions. And I think that the comment really highlights a lot of important issues. One thing is that the whole guideline is really, unfortunately, based on relatively sparse evidence, simply because we were not able to find a lot of evidence on these issues that are quite important. and also the fact that it is really a challenge to evaluate pain in patients with advanced dementia because of communicative difficulties perhaps in interpreting pain, etc. And I think also that again, our recommendation is not that mild analgesics should not be used at all, but it should not deflect away from the fact that we also need to consider other reasons and do the diagnostic workup. I don't know if any of you and Dr. Verdelho and Dr. Nilsson, you're welcome to also chime in here if you have anything to add, of course, to what I've just said.
If I may add,
yeah, go ahead.
I think it's important that we are always, it doesn't matter. I mean, we as the doctors treating the pain, we should always follow this stepwise approach, I think, and taking into account the fact that we have the dementia or elderly in front of us. This is an additional challenge for the therapist. So I think we should always start with the simplest possible, and then adjust if it's needed to give a stronger one, and of course then also re-evaluate after a while if it's really needed, because we know from the practice that patients with dementia would get a certain treatment, either analgesics or antipsychotics, and they would have it for until the end. Yeah. So it's very common that nobody really checks whether they still need it, or maybe it would be good to change it for something else. So this is, I think, one of the joint issues that we are trying to give to the audience or to the with these guidelines, because those patients really need follow-ups and again re-decision whether the certain treatment is needed now or still or not. So
if I may,
go ahead.
Yeah, I would really reinforce this idea. I think it was one of the lessons learned from the revision we did, is that although we don't have enough evidence to sustain that we should keep these patients to be seen regularly, what we realize is that there is a tendency to start medications for pain or for behavior that nobody really looks again. So it is our responsibility to check for the patient on a regular basis to be certain that if we stop that medication that was started because there was a suspicion of pain or because that was a very disruptive behavior, sometimes not only the behavior or the pain disappeared and we did not nothing about the drug, as they can fluctuate. And again, we should have the courage to interrupt, to withdraw the drug and to test, is it really efficient? Is it really working? And for this, to see the patient, it's highly relevant. So we can withdraw drugs that we may think they are not longer necessary. So it's really to reinforce this idea.
Yeah, and I think both you and Professor Kramberger really made a very nice segue into the next issue, perhaps, about the systematic medical follow-up. That is also one of the issues in the guideline, and where we recommend that patients with dementia should have follow-up. And Professor Verdelho, you already very nicely illustrated why this is important. I think that also one of the issues that we mentioned is the fact that patients with dementia really have a lack of insight. Many patients with dementia have a lack of insight, so they do not report symptoms that they're feeling, or they are not they do not have insight to acknowledge that they need regular follow-up and so forth. And I just want to sort of get an idea about what you all think about this issue of systematic medical follow-up. What is it like in the countries you practice? Is it possible to follow patients with dementia, or how is it?
We do it regularly because in our country, for the prescription for anti-dementia drugs, only neurologists and psychiatrists can do it. So, and we need to renew the prescription each 6 months at least. So we usually see patients, but in fact, I think that more than that, the clinician or the technician that takes care of a patient with dementia needs to be trained on that. And of course that all the relatives know very well the patient, but the technicians or the doctors that are trained in dementia can identify some problems that otherwise will not be identified in a non-specific appointment, in my opinion, of course.
Yeah, and I think that's a good point, that caring for patients with dementia as a physician is something that you need some training in. Maybe it can. I think it can also be done by general practitioners, for example. But they need special training. I think I completely agree with you. I don't know if any of you, Dr. Nilsson or Professor Kramberger, have anything to add.
Yeah, well, I think that there could be a problem with resources allocated for that kind of systematic follow-up in sort of really specialist clinics. We not in Sweden have the restriction that it's only neurologists and psychiatrists that can prescribe. So common forms of dementia will often be followed on long-term basis by the general primary care physician and their team. So it will be often multi-professional, but so some kind of team basis. But the experience among these can vary, of course, especially among the physicians. So, of course, training is very, very important, and proper support. We do provide, I think, quite good support from the specialist clinics as soon as there are any problems, but the systematic follow-up would vary, I think, depending on local conditions and the Swedish perspective.
Yeah, I think the situation is probably a bit similar in Denmark, where I practice, and but I think that one of the issues that can occur if you are not knowledgeable about dementia care is the fact that patients will not themselves go to their doctor if they feel anything. It has to be pre-planned for a lot of these patients, or they have to have caregivers who make sure they go to the doctor. And the same thing about questioning patients with dementia. It takes more to elicit symptoms and signs than asking if they are doing well. You have to be very specific, and often also you have to involve the caregiver, at least, I think. And that could be one concern with maybe doctors that are not as experienced with dealing with patients with dementia. I see that there's a comment from Gail. I just want to read it out. It says, absolutely agree with that on the systematic medical follow-up. These patients sometimes fall by the wayside when it comes to med review for the reasons Kristian outlined. They are supposed to have annual reviews, including medication reconciliation by GP practices. In practice, anecdotally, this does not happen as it should, and I think that we can probably all agree to that there are a lot of patients that fall through the cracks, so to speak, especially with the review of medication. I think I just want to move on to the last issue in the guideline, because we only have about 8 minutes left of the session, and that's the issue of antipsychotics. And I think this is a really has been and is a hot topic, and has been for many years, due to the fact that we know from epidemiological studies that use of antipsychotics in patients with dementia is really very prevalent. And we also have very good evidence now, and has had for many years, that there is considerable morbidity as well as mortality associated with treatment with antipsychotics. And I think reading our the guideline, one thing that can be a bit confusing is that we have actually two recommendations that may be seen as a bit opposed. We have this recommendation of a weak recommendation against the use of atypical antipsychotics versus no treatment, and a weak recommendation for use of atypical antipsychotics versus haloperidol. And that can seem a bit contradictory. I don't know if one of you wants to try to elucidate this seemingly contradictive recommendations for the audience.
If I may summarize, the idea is, in an ideal world, we should not use them at all. But when needed, we cannot say a name, but we recommend an atypical in the treatment to the old ones. I think it was our finding together.
Yeah, I totally agree with you. I mean, we will end up in situations with patients that are agitated and aggressive where we have to subscribe antipsychotics when non-pharmacological treatment and so forth hasn't been effective, and in those situations, then our recommendation is to use an atypical antipsychotic over the haloperidol. Thank you for clarifying that, Dr. Verdelho. I also think that one of the I think we already touched upon this, especially Professor Kramberger on opioids as well. But we also have a recommendation with regards to antipsychotics on discontinuation of antipsychotics, and maybe Dr. Nilsson, you will maybe can you elaborate a bit upon that, and what are your routines with regards to prescribing antipsychotics? What do you want to make sure before you do it, and in the follow-up of patients?
Yeah, so of course, as we talked about with pain, you have to be absolutely certain that there's only a sort of a psychiatric cognitive cause for the agitation aggression. So a thorough assessment, both from history and physical assessment, is of course necessary to start with. And as you said, I mean, there are lots of non-pharmacological behavioral interventions that you could use that will often alleviate the situation. You could use some of the choline esterase inhibitors, or even memantine, if they have not been used previously, or if the patient is not on that. And then comes the most important point: to use very low doses, a slow titration, and in my view, a very rapid follow-up. So a follow-up within 2 or 3 weeks to see that A, did it have any positive effect on the agitation and aggression, and B, were there unwanted side effects which might mean that you cannot use this, or you have to decrease the dosage. That is my sort of way to work with these issues.
And I think
actually, I would say it's the same with anti-epileptics or opioids. The rapid follow-up and low dosages is absolutely necessary.
And I think that we also recommend risperidone in the guidelines specifically, because this is that's where the best evidence is for efficacy, and also that this is the only drug approved for treatment in patients with dementia. And I think one of the things that I like about that drug is that you can give a very, very small dosage, 0.25 milligrams. And sometimes that's effectively. Also, I think another issue is that it's really important to get the caregivers on board as well. You have to have a good talk about when initiating antipsychotics, not only side effects, but also what can be expected of the efficacy, because if caregivers expect that the behavioral disturbances will go away completely, then a 50% reduction might feel as a disappointment, or or that the therapy is not working. What are your thoughts about my comments here, Dr. Nilsson?
Right. No, of course. I mean, this dialogue is very, very important. Might also mean that you don't need to use any drug at all in a certain situation. If you could clarify, and you should have some kind of systematic way of working with this in a specialist service, visiting patients and carers in the nursing homes, an approach so that you really try all other measures before you start treatment with an antipsychotic.
Okay, excellent. So I think we're about nearing the end of this session. I would like to thank all of you, all of the panel members here at the session for giving us your time and valuable advice and comments on the European Academy of Neurology Guideline on medical management issues of dementia. And I also would like to thank the audience who have zoomed into this session and who have also come up with some very nice comments to this session. So without further ado, I would like to say goodbye to all of you and have a nice rest of the conference. Bye.
Bye.